I'm excited to be here among you to talk about Oceanic AF trial, which I think it's very well needed these days. And as you see, it's a phase 3 program looking at the efficacy and safety of asundexian, which is a novel oral factor XI inhibitor in patients with non-valvular atrial fibrillation. As you know, we have multiple different anticoagulants, especially the DOACs, focusing on anti-10As. We've seen a lot of increase of use of the anti-10As. At the same time, we saw a significant increase in bleeding. As you can see from the slide here, annual hospitalization of related to major bleeding has been increasing after the usage of anti-10As, including apixaban and rivaroxaban, and mortality related to bleed has been increasing. Even if you look at the ROCKET AF and Aristotle trials for rivaroxaban and apixaban, major bleeding risk is not really little. It's 3.6, 2.3 to 13%. And you see mortality related to intracranial hemorrhage has been increasing. So it's been a lot of research to look at different anticoagulants, looking at factor XI inhibitors, actually looking at the mice studies. They found that mice with factor XI deficiency, they had really less thrombotic or thrombotic complications or thrombosis formation without significant increase in bleeding, even with an addition of antiplatelet therapy, contrast to what we saw with the DOACs. And we also know from human studies, patients who are deficient for factor XI, they did not have significant increase in bleeding, yet they did have reduced risk of thrombosis, even like thromboembolic event in AF patient with factor XI deficiency. So that's why there's been some trials and studies looking at factor XI, inhibiting factor XI, and including phase 1 trial that showed no significant increase of bleeding when you inhibit factor XI. Phase 2 studies focusing on the Pacific study, looking at patients with non-valvular atrial fibrillation, about 4,100 patients that were randomized to receive asundexian versus apixaban. They were actually less bleeding complications, especially in the clinically relevant non-major bleeding complication with asundexian versus apixaban in patients with non-valvular atrial fibrillation. And now, we're going to try the Oceanic AF trial to look into the efficacy and safety in phase 3 trial. So why factor XI, right? And as you see from the slide here, we all know that there are two different cascades for the coagulation. The extrinsic pathway or tissue pathway that's responsible for physiological thrombus formation. So when you have a skin cut, the platelets stick and the coagulation factors jump there to stop the bleeding. And there's the intrinsic pathway. I'm trying to show the right here. And there's the intrinsic pathway that's responsible usually for pathological thrombus formation intravascularly. So if we can just inhibit the intrinsic pathway, hence stopping the pathological thrombus formation, that would be a great idea. And that's where factor XI is taking place right here. So by inhibiting factor XI only, you only inhibit intrinsic pathway and hence inhibit the pathological thrombus formation, and you leave the tissue pathway or extrinsic pathway intact, so you can still have the physiological thrombus and formation. And that's why. And then the previous anticoagulants that we had for a while, heparin, vitamin K antagonists, DOACs, they all inhibit both pathways, the intrinsic and extrinsic, and hence we had seen increased risk of bleeding when we inhibit the thrombus formation. And this is the slide that can look at the study design, and we would love to help us in recruiting patients. Again, it's a phase 3 program. It's an international multi-center randomized trial looking at the efficacy and safety of asundexian, 50 milligram versus apixaban, 2.5 versus 5, or 5 milligram twice daily in patients with non-valvular atrial fibrillation, looking at the safety and efficacy of asundexian in these patients. So we're looking for patients with documented atrial fibrillation, and they have an indication for oral anticoagulation, and they should not have an indication for oral anticoagulation or other indication for oral anticoagulation like DVT or PE. And those patients should have a CHA2DS2-VASc score 3 or more if they are male, or 4 or more if female, or you could also have 2 or 3 in terms of male, 2 score 2 for male, or score 3 for female if they have additional risk factor, which is listed down here in terms of age and previous TRA or systemic embolism. And exclusion criteria if they have mechanical valve, moderate to severe mitral stenosis, is the regular stuff for exclusion, or significant renal insufficiency. And so those patients, we're going to follow them for the primary efficacy endpoint of composite stroke is systemic embolism, the primary safety endpoint of major bleed based on the ISTH criteria. And then there will be some secondary endpoints. So what we're trying to do actually right now is to kind of screen the EP clinics here, as well as my clinic, because I see a lot of patients with AFib as well too, and try to kind of, we've probably been screening about 75 patients a week with the help of our coordinators led by Jessica Whelan. Thank you, Jessica, for all the great work that you've been doing, and congratulations for recruiting our first patient. Already we have our first patient recruited. That's great work within a very short period of time. And then, so we accept referral as well. If you have a patient in your clinic, atrial fibrillation, good candidate, please make sure that you send us an in-basket to the to MCHHEP Oceanic-AF, or you can page me, page Jessica and the team, and we'll be happy to come down and help you as well. I'd like to stop here and give time for the ground round. I appreciate you considering patients, again, with non-valvular atrial fibrillation. They have indication for anticoagulation and no other indication for anticoagulation like venous thromboembolism. And then we'll be happy to help you. And thank you so much for having me this morning. Thanks.
Like if they're already on Eliquis, can you?
Yeah. So existing or new, that's fine. Yeah, okay. Existing, we can actually wash out the whatever drug they were on and randomize them. Correct, yes. Thank you.
All right. Oh, thanks, Nita. Interesting to see that they accept TAVR, huh? And TAVR is okay. Yes. So it's going to be an interesting one. All right. So our task this morning, and thank you for coming, myself and Dr. Sandoval, was to talk about this entity of microvascular coronary disease, or coronary microvascular disease, I should say. It's going to be abbreviated by CMD. And the opportunity for us to understand better and diagnose this through non-invasive as well as through invasive strategies. And whenever you have two individuals to explain one problem, there is a problem already. So in their understanding. Start with this statement here. Not all that wheezes is asthma, and not all that causes angina is epicardial coronary disease. As we know that coronary artery disease obviously is a ubiquitous problem, and we treat this very well. We have incredible treatments. But it's humbling to see that this phenomena, that despite patients being treated with epicardial coronary disease with stents, almost 40% of these patients will continue to have angina. You treat it, they feel great, and then the epicardial coronary disease has been treated, but it's a microvascular, it's a microcirculation. And as you can see, this was one of the first studies to this coronary syndrome, or syndrome X, to show that the lack of the flow augmentation and this blunting was associated with potentially this entity with typical ST changes. This is a problem predominantly of women, although not only for women, but women tend to manifest this 3-to-1 ratio, female versus male. It's an etiology that has been pretty much not so well paid attention to it because of our lack of understanding of what could be done to potentially investigate. And now, with the advance of, many invasive and non-invasive etiologies will start to now resurrect that. And that's what we're going to be touched upon. As you can see, the coronary tree, the epicardial coronary artery that we treat with stents is going to go through a multitude of branching from pre-arterioles to arterioles to then capillaries. And as it moves down from the epicardial into the myocardium, there's going to be obviously an increased resistance in anything that is going to be surrounding that environment to making it stiff and to make these pre-arterioles not being able to vasodilate, or intrinsically increase the thickness of that wall is going to provide the lack of impaired vasodilation, is not going to be able to augment that flow. That's one mechanism. The second one that we're going to talk about is obviously the structural alterations that we talked about. The other one is the impaired vasodilation. And that could be endothelium-mediated and non-endothelium-mediated, and I'll let Dr. Sandoval explain about this. But it boils down to the lack of ability to increase the myocardial blood flow into the most distal segments from the epicardium. Many things that the coronary microvascular dysfunction involves has been already paid great understanding with this nice review by Del Buono and Filippo Crea. Many entities like the HFpEF that we're going to talk briefly about that increases this microvascular inflammation, increases myocardial stiffness. Obviously, patients that have obstructive coronary artery disease also will have a greater likelihood of have coronary microvascular disease. We'll touch upon Takatsubo. We'll talk about this entity of INOCA, or ischemia with non-obstructive coronary arteries, and many other things that also could cause coronary microvascular dysfunction. Even when treating a myocardial infarction, that embolization of debris will cause alterations of the microvasculature, albeit transient. So with all of that, then, the understanding is that the mechanisms of this impaired increase of the myocardial blood flow could come from both structural changes of the vessel or functional mechanisms of the vessel, and also the environment, all of which will cause the lack of ability to increase the flow. Subgroups that we are starting to recognize that are important contributors and potentially quite commonly associated with this entity are all of those here, as you can see in red. INOCA, ischemia with non-obstructive coronary disease, women, HFpEF, morbid obesity, insulin resistance, patients with prior coronary disease, patients with cardiomyopathy, chronic kidney disease. And there are several other potential therapies, including obviously coronary vascularization. You got to take care of what you can with the stents or medical therapy. Obviously, you got to. There's a lot of interest now of the potential that SGLT2 inhibitors could have and GLP-1 could have, in the sense of not only improving myocardial blood flow and stiffness, but also producing weight loss, which obviously would improve the whole metabolic milieu of these patients, as you can see also here, gastric bypass. How do we make that diagnosis? There are 4 criteria, as you can see here from top to bottom. You got to have symptoms of myocardial ischemia with effort or even sometimes at rest. That's a bit unusual, but patients with coronary microvascular disease can have symptoms of angina at rest. So that's something to consider. You have to obviously exclude obstructive coronary disease, either by coronary CT or by invasive coronary angiography. Yeah, you're going to have objective evidence of myocardial ischemia by manifestation that into stress, myocardial perfusion imaging, or by abnormalities on the coronary flow reserve when you do this invasively or by CT-FFR. And obviously, as Yader is going to talk about, all these measurements that one can do also invasively to confirm much more definitively from coronary flow reserve, CFR, as well as the index of microvascular resistance, IMR, that we're going to talk about that. There is also a component of the vasospastic angina that is also something that non-invasive imaging has a difficulty into diagnosing that. This is less common than the much more common microvascular angina, but that relies also the opportunity to diagnose that into the cath lab with acetylcholine provocation test. Definitive test is if you have obviously all the criteria, you have all the 4 of them. 3 to 4, it could be almost there, equivocal, or present, and should warrant potentially the reservation for more invasive testing. Why is this important? Why coronary flow reserve, which is what we measure with the augmentation of flow with adenosine? Why is that important? The abnormal flow reserve is obviously associated with an increased risk of MACE and increased risk of mortality when you look at this very recent meta-analysis of almost 60,000 patients. And then they look into several other subgroups. If you have abnormal coronary flow reserve in acute coronary syndrome that's bad, chronic coronary syndrome, heart failure, transplant, diabetes, aortic stenosis, sclerosis, sepsis, and also when that is captured by either PET or by cardiac MRI or by invasive. As you can see, and we will talk about that, PET has a much longer history given its ability to diagnose this problem. And cardiac MRI now is a new kid that has provided a lot of new insights. When we talk about this entity as well, we cannot obviously dissociate with other problems like we talked about. This is relationship with an analyzed adjusted rate of symptoms and events. When you have abnormal coronary flow reserve, there is a trend of association. The worse the coronary flow reserve, the likelihood of increased filling pressures, so E over E prime. You know, the more filling and the more congested you are, more likely that it's going to be harder to perfuse these coronary arteries. And you can see here the separation, the freedom from event. These patients with abnormal flow reserve and increased filling pressures, they do worse. And that's what this study by Viviani Tacchetti shows. When we're going to diagnose this, we ought to use objective quantification. That's what it's going to come down. And these are the guidelines from a couple of years ago showing that when we have stable chest pain and we're suspecting this INOCA, and these are the factors that we talked about, they're associated with the coronary microvascular dysfunction, stress PET or stress CMR must be with myocardial blood flow reserve, myocardial blood flow quantification. So obviously here we are really spoiled because we have the privilege of having both modalities available to us with this quantification, and we're going to talk about that with a couple scenarios and cases. That's not to say that we could not do this with echocardiography. Echocardiography is possible, but obviously requires expertise, and we're going to be probing the LAD only, when obviously this could be multivessel and intends to be in multiple coronary territories, but the LAD is the most common one. And the coronary CT, we're going to talk about that briefly, but also some recent developments. Perfusion by CT can be done, although this comes at a higher exposure of radiation as well as contrast exposure for these patients. And for both PET and CMR, what is considered abnormal is the myocardial perfusion reserve less than 2, and whereas PET here is the gold standard with the costs higher than MRI with obviously some radiation exposure to these patients. Regardless of what we and how we diagnose these patients, either invasively or by PET or by CMR, the association with the outcomes with MACE is there for abnormal coronary flow reserve when you exclude patients that have obstructive coronary disease. So flow is important, and we should be measuring that to try to understand what our patients are feeling. Talking about PET, this is work by Paolo Camici and also by Filippo Crea, showing that the PET, when done with water or ammonia, which has a very close linear correlation microspheres, you can see that it tracks very well myocardial blood flow. And you can see that patients with no obstructive coronary disease and no coronary microvascular dysfunction, when subjected to adenosine, should have an increase in that myocardial blood flow to about 3 to 5, 3 to 3.5 to 4. So anything below that, and typically for our non-invasive measurements, we consider stress myocardial blood flow around normal between 2 to 4. Let's take a case, and these are cases from us here. Oh, this is going faster here. So 74-year-old female, a BMI of 24, has a history of COPD, hypertension, prior COVID, myocoronary calcification, presented with exertional dyspnea. These are her stress PET images here. As you can see, on the top, stress, the bottom, the rest. Would argue that there's pretty much no significant reversible ischemia. It's pretty much a normal study. Then the quantification of that is available on the software. We do this and we acquire with myocardial blood flow quantification. It divides by the 3 territories, the 3 segments. You can see here for the LAD, rest, stress, and the reserve. So the average here is about 2.3. So for LAD, it goes from 1.6 to 2.6. Reserve from 1.2 to 2, and from 1.5 to 2.4. So normal myocardial blood flow at stress, and normal myocardial, slightly reduced myocardial flow reserve for this patient, but always available. Contrast that with this other patient, 68-year-old female, history of dyslipidemia, hypertension, type 2 diabetes with elevated coronary calcium score, but no obstructive disease to known. And she had a 50-pound weight loss with Ozempic. That's now a trendy thing. Presented with exertional dyspnea. As you can see here also with rest and stress comparison, there's no obvious reversible myocardial ischemia. The sum stress score is 0. And when we look into the myocardial perfusion reserve, her peak myocardial blood flow is only 1.7. So where it should be around 2.5 or greater, right? So perfusion is normal, objectively, yet she has coronary microvascular disease. So, in part, obviously she has the whole setup, right? She has type 2 diabetes, hypertension, obesity, and coronary calcification. So all of that. So even though we don't have epicardial coronary disease here, we have manifestation of microvascular disease. And it's not until we go into that tab. So let's not forget about that quantification of flow. That's where the money is. And literally, actually, there is a better reimbursement for that if you charge. So, so pun intended. All right, for coronary CT, this is a work that actually our colleague, friend John Lasser was part of that as well. One concept is that, in patients that have coronary microvascular disease, there is typically a decreased ratio between the volume of coronary to the myocardial mass. So patients that have either an increased mass, so hypertrophy, they're going to have a lower V2M ratio, or they have coronaries that could not vasodilate, so a lower V2M. And what they saw is that, in patients that have minimal stenosis 30% versus patients that we're starting to get into the intermediate, when you have a low V2M ratio, some of these patients might have already a positive FFR. You can see here that there's quite a big spread, even in the absence of significant obstructive disease. And that could be an indirect sign of potentially a coronary microvascular dysfunction. As you can see here, there's a wire, there's an FFR of 0.70 in a patient with no significant obstructive disease, but a lower V2M ratio versus a patient that could vasodilate. You can see there's much more coronary calcified atherosclerosis that is not allowing these coronaries to vasodilate. All right. Now switching gears from PET to cardiac MR. What is possible on MRI? And MRI obviously comes in a little bit late in comparison to stress PET. As you can see here on the left side, this visual assessment, which we'll still do, sometimes can be difficult and is time consuming and sometimes can be a bit subjective. Whereas the quantification through the perfusion maps is much more objective and very clearly seen. That's what actually we get by the nuclear on the PET, so why not have that available to us? The quantification that is provided by the maps allows us to obviously identify what is single vessel, what is triple vessel disease. As you can see here, in a completely normal subject, you go from blue to this very high myocardial blood flow of about 4.5 to 5. And in patients that have single coronary artery disease, you can see here the RCA, and you can see here on the quantitative, but the maps become much better and when you have patients with diffuse triple vessel disease. That's what has been shown, is that for single vessel disease, assessment by visual comparing to perfusion maps does not add so much, but as we increase the complexity, you can see that the perfusion maps tend to pick up much more. Of course, if you already have one vessel, you could already send this patient to invasive coronary angiography, but that might change completely the strategy of treatment of this patient. These are some examples from our lab here, and this could not be done without the collaboration that we have with Dr. Peter Kemmer from the NIH. He has been really the pioneer to implement this as an inline quantification. So this is, as the images are being acquired, the computer is doing all this generation of these maps, and this is not ubiquitous available. We are only probably the third or fourth center in US. It's not only Abbott Northwestern, by the way. This is actually available at United as well with my colleague Eric Shelbert. So as you can see here, now we can increase the coverage. Typically in cardiac MRI, we would have done 3 short axes. Here we have 6, so we go every other heartbeat, and you can see here an incredible increased ischemia as well as peri-infarct ischemia. So these are the late GAD images with dark blood. You can see a small subendocardial infarct in bright white, and you can see the ischemia extending much beyond into what is infarct, and the lack of augmentation of flow. This patient goes from 0.9 to only 1.1, significantly impaired. This invasive quantification has been validated against coronary physiology, as Yader is going to talk about that. As you can see here, a patient with very low IMR, very low normal FFR. I don't know what they're highlighting here because this IMR is 11. It should be is normal, 11, and a patient that has an IMR of 56. Anything above 25 is abnormal. You can see a normal myocardial blood flow, normal IMR, patient with a stress perfusion, and a patient with globally diffused disease, and a patient with increased IMR. This methodology of quantification by cardiac MRI has been validated against the PET, and we just talked that PET is the reference standard. So the myocardial perfusion by PET correlates very well with the quantification by myocardial blood flow with cardiac MRI. Obviously, these were not patients that would sometimes see it here with devices, with arrhythmias, with obesity. All of that increases the complexity of, obviously, this methodology, and we have to sometimes rely on the visual assessment, albeit quantification is possible in the vast majority of the patients. And again, showing that the quantification of this methodology correlates well with PET by this group from Sweden. Is there also prognostic value, similar to what I showed by PET with the coronary flow reserve? This is the largest study to date using this methodology with this automatic AI, artificial intelligence derived myocardial blood flow and perfusion reserve, more than 1,000 patients from UK, 2 center studies. This is the artificial intelligence segmentation of the myocardium at rest and then at stress. And what they were able to show is that the stress myocardial blood flow less than 2, so here it should be greater than 2. You can see that these patients do better if they have a stress myocardial blood flow that is decreased, as well as a perfusion reserve, and here was around 2.4. And this perfusion reserve, when abnormal, similar to PET, is associated with events with this hazard ratio after multiple adjustments. So again, diagnosing not only coronary artery disease, epicardial coronary disease, but also highlighting the importance of the perfusion reserve by cardiac MRI. As I mentioned before, we are very privileged to have this readily available to our patients. This is a patient with the normal stress myocardial blood flow. It goes from 0.7 to 2.8, contrasting with this patient from 0.9 to 1.9 and diffusely mildly decreased throughout. Let's take another case as well, now highlighting how we can do this with MRI. This was a patient that one of our colleagues was taking care of, 75-year-old female, hypertension, dyslipidemia, obesity, prior gastric bypass, low coronary calcium score of 187, presenting with exertional dyspnea and vague retrosternal chest pain. As you can see in this outside nuclear stress test, I don't see a significant change here. The way this was interpreted was there was a small area of mild ischemia in the mid-apical anterior, whether this is breast attenuation, but preserved ejection fraction. So this was followed by coronary CT with the FFR, intermediate lesion found in the mid-LAD, and the FFR of 0.87. She was treated medically, and she was then followed with, again, recurrence of chest pain. She was sent to the cath lab, and you can see her coronary angiogram there. Oops, going a little bit fast. But no significant obstructive disease. There was no provocation. There was no hemodynamic physiology done for these coronaries. You can see on the cardiac MRI there, preserved systolic function. don't know what it's doing with my slides here, moving faster. And you can see some aortic sclerosis, but let me just highlight this here. There's increase of the myocardial ECV, so some element of fibrosis, 33%, and no significant late GAD. Preserved systolic function with mild LVH. These are her perfusion images. Again, the qualitative visual assessment, 6 slices. And you can see if I pause here, at the end of systole, I already went to the perfusion maps, you can see this diffuse subendocardial ischemia that is seen in this patient. Seems to be worse involving this apical inferior segment, but diffusely abnormal. You can see that her stress myocardial blood flow is only 1.6. So this is with 170 micrograms of adenosine. And the perfusion maps according to the territories, where the LAD is the worst, 1.3, 1.6, and 1.7, 1.8. So this patient, and you can see, so it's globally diffuse, worse in the LAD, whereas where we see that intermediate lesion. So this patient has been put into a regimen with vasodilators, as well as treating her hypertension, and is feeling better. Take a look at this other case here, 25-year-old, quite young, with hypertension, diabetes, polycystic ovarian syndrome, thick walls, hypertensive, with a small pericardial effusion. And you can see already this fluffy, ill-defined, non-ischemic late GAD, likely due to her hypertrophy. The myocardial ECV is elevated at 31%. And these are her stress images. It's very bad. I mean, it goes from 0.5 to 1.2. So she cannot augment that flow. And obviously, there are several other things here that are leading into this, but showing the capability to diagnose not only epicardial disease, but also the potential to diagnose microvascular disease. To wrap it up, where are we going with this? Another case here, some future directions. I don't know why these slides are going like this. She's a 72 female orthotopic heart transplant 7 years ago. Found to have cardiac allograft vasculopathy, a mid-LAD of 20% stenosis. She has preserved ejection fraction, and as you can see, as part of her transplant, there are many coronary angiograms that she goes through, right? And that's a paradigm that we will potentially consider. Can we look into, obviously, this non-invasively? These are her stress perfusion images. And again, as shown for many of these other cases, there's no significant reversible defects. When we look into her flows, however, we can see that she goes from 1.2 to 1.6. And her perfusion reserve is 1.4. So this, despite the perfusion being normal, the flows are not. That's the theme of the day, that we need to look into that. Why is that important, particularly for transplant patients? Because these patients could have 3 groups here. It could be epicardial coronary disease, that you're going to have an obvious ischemia, and patients that would have myocardial blood flow greater than 2. You could have patients with microvascular coronary allograft vasculopathy, where the myocardial perfusion reserve is less than 2, and there's no ischemia or epicardial coronary disease. And you could have both components. So this patient would fall into this microvascular coronary vasculopathy. And the importance of the flows and the flow reserve in this case here is that that associates, even in the absence of epicardial coronary disease. You can see that epicardial is the light blue here. The presence of microvascular allograft vasculopathy, which is what this patient has, is associated with impaired outcomes for this patient. So we got to treat also, and got to pay attention to that. Another interesting development that this recent EACVI last week is the potential also of perfusion being an upstream marker of disease. So these are patients with hypertrophic cardiomyopathy, genotype positive, but no LVH. You can see no LVH, but they already have perfusion reserve. So is perfusion a marker of impaired before, obviously, these patients manifest the hypertrophy? With our colleague, Dr. Sharkey and Ritu Saxena, we're looking into using this, obviously, in patients with Takotsubo syndrome. So with the edema is going to create a bad environment for this microvasculature to obviously perfuse. And we can see here with the stress myocardial blood flow, there is a ratio between the basal segments to the apex. As you can see, there's no edema at the basal, but there is edema at the apex. So this basal to apex ratio greater than 1.5 is what we have found to identify these patients. And the good news is that these patients, after 6 months, when they come back, the edema obviously resolves, the contractility improves, and the perfusion improves for these patients. Lastly, what is happening with CT as well, and this is from EuroPCR slides, as you can see from last week as well, showing that this index of microvascular resistance reserve, which is what is the microvascular circulation, the flow at the hyperemic state is going to be done, is something that is being developed now by CT. This is a recent study showing this microvascular resistance reserve less than 2.1 is a marker of coronary microvascular disease. And this work that was recently presented validated against a water PET by CT, looking at the quantification of myocardial blood flow, was able to have an excellent correlation with PET. So looking at all the territories, you can see for LAD, circumflex, and RCA, the simulation of what by CT was able to do matches pretty closely with what the stress PET is. So opening up the possibility for CT to also now not only look at the epicardial coronary disease and measure obviously the FFR, but measure obviously this myocardial resistance reserve. So in closing, CMD is common, and we gotta obviously exclude epicardial coronary disease, but we have to understand better why some of these patients will still remain symptomatic. It is mostly a female problem, and obviously the comorbidities that come with that will increase the risk. Stress PET has been validated, and it has an accurate detection of this problem. We gotta quantify both myocardial blood flow and the flow reserve. Stress MRI is more recent, but now we have the inline automated quantitative perfusion available on both campuses, which now will provide objective assessment. And several new developments on both imaging and, as we hear, will allow us to do this better. Thank you.
Working. That was wonderful, João. Let me ask you something before I start. So, just a practical question. Can you provide some general guidance as to which one should we order, PET or MRI, and whether there's any guidance as to whether they should hold their nitrates or medications or coffee, caffeine, just for basic?
Yeah, so great practical question. So I would say that both of them are going to give you that answer. When to order one versus the other is when you're looking for more than one justification. So does this patient have a cardiomyopathy? Does this patient have a valvular disease? Does this patient has an aortopathy as well, which will be harder for you to obviously capture? It does not do that with a PET. Availability is also another issue. How quick can we get? Stress PET has a much greater access, and we wanted to increase MRI with now starting this week 12 slots a day. So it's going to improve our access to these patients, and we have 2 campuses. But it's when you have more than one question. And I think that is, that's how we would frame.
The coverage, insurance coverage, will both be covered?
Yes, so for insurance coverage, majority of the insurance companies now are already covering stress PET. As a matter of fact, when stress SPECT is ordered, we try to convert to PET because better reimbursement, better is a shorter study and there's less radiation for the patient, and you have the capability to quantify. Obviously, it's only available here. It's not available at United. But the insurance companies are providing that. The myocardial blood flow quantification by MRI is something that is in development, not available. Yes, John.
Currently, you have to ask for coronary flow reserve on the PET.
Yeah.
That's true. That's true. At the moment now, if you wanted to have the flow reserve, please order that. Although the results are always there, we can always go retroactively and take a look, but you have to check that box as well.
Perfect. Thank you,
Thank
João.
you.
That was just wonderful. So we'll switch to now to the invasive evaluation. I do consult for both Abbott and Philips, which are Doppler and thermodilution. So João already went at depth into the details of the, what is the disease and why this is important. I just want to provide another perspective on why this has changed You may wonder why we haven't talked so much about this in the past years. I mean, like I trained not long ago, and microvascular disease was really not as central as it is now in 2023. What changed? One thing that changes first, just the nomenclature. The nomenclature has changed in which previously we were all emphasizing obstructive disease, myocardial infarction, there's atherosclerosis, but now the nomenclature has changed in which there's an increasing recognition and just understanding that there are patients with ischemic heart disease that if they're stable or acute, they can have ischemia with no obstructive coronary artery disease. So there's increasing emphasis just in identifying these patients. This was previously not the case. You would do the angiogram, you would say you have no obstructive disease, pat on the back, maybe it's something else. So just this increasing recognition. Why are we talking about this more? This, I think, Dr. Colin Berry was here, I believe, for virtual grand rounds last year or a couple of years ago. The other one is that we have randomized data. So this was probably, I would argue, the most important thing that changed in the field and the reason we are talking about this more. We're talking about this more because it's no longer something academic that it's happening at a couple of centers. Now we have randomized data that has pushed the field exponentially. This is a Carmica. I know it was discussed at length by Dr. Berry, but in short, just a randomized trial. And I think it's elegant, right, that sometimes just a small trial of just 150 patients that really changed the field and randomized patients to an arm in which coronary function was not disclosed and another arm of 75 patients in which coronary function was disclosed. And by disclosing that information and following the guidance from that approach, you improve pretty much quality of life and angina scores. So there's value in knowing this information. So improve identification by the nomenclature, randomized data, and now importantly, the guidelines, the recent 2021 ACC/AHA chest pain guidelines now clearly provide class 2 recommendations to evaluate microvascular disease. So all of these are the reasons why 5-10 years ago, it was pretty, if we are honest, we were not really talking about this. And now this is an increasing discussion. As you can see, for the modalities that Dr. Cavalcante discussed, there's class 2A recommendations for stress PET and stress EMR, and there's a class 2A recommendation for invasive coronary discussion. So I want to really highlight something that sometimes we may take for granted. I don't think there are many, if any, institutions in the country, probably limited, that have 4 modalities. We have MRI, we have PET, we have thermodilution, and we have Doppler. That is a unique privilege that really positions us to be pretty much global leaders on this. We have really all the modalities available to evaluate microvascular disease. And you already talked about this, but this is the issue, right? This is our simplistic view of the luminogram. We looked at there's no significant obstructive disease either in the acute or the stable setting, and we all take a step back and say, well, nothing's happening. But the reality is that if you think about the ischemic heart disease, think about this huge tree of microvascular network that we are really dismissing if we don't interrogate it appropriately. João already talked about the pathophysiology and the prognostic implication of the disease. I do think it's also important to talk about the classification. Often, I think João mentioned that in his slide, often we focus on relatively healthy young women that have INOCA or MINOCA. But think about the types. That's often just type 1MI, type 1MI coronary microvascular disease, which is in the absence of structural heart disease. But as alluded, there's a number of other types that can occur with cardiomyopathies, obstructive coronary artery disease after PCI, and it was addressed after transplantation. So there's a number of subtypes. Type 1 is often the one that gets sort of like the hook, that it's sort of like young women with microvascular disease, but there are all these other subtypes of coronary microvascular dysfunction. So really my whole goal is to provide a more pragmatic discussion of how do we evaluate this in the cath lab. This is actually an algorithm from the 2021 AHA ACC chest pain guidelines from 2021. And I do want to highlight that here, as it says, it's stable chest pain, suspected INOCA. Even though it's very valuable that we have non-invasive approaches such as MR and PET, it is clearly noted by the guidelines that this non-invasive testing is more prevalent, but that invasive assessment is more comprehensive because it can really provide you more specific phenotypes of understanding what particular subset of microvascular disease you have. and I'll discuss about why that's important. But again, keep in mind that if you want to provide the most comprehensive approach, the guidelines will recognize that the invasive approach is still the gold standard in that aspect. And why is that? I was actually considering entitling this talk Beyond CFR, because when we talk about PET and MR, it's really focusing only in coronary blood flow and CFR. Whereas if you think about microvascular disease, there's a bunch of different phenotypes of microvascular disease that are not addressed by the non-invasive testing. This is actually even a simplistic view of it, but if you think about microvascular disease, you can think about whether it's the abnormality in the non-endothelium dependent microvascular function that you address with adenosine and coronary flow reserve. That is largely what non-invasive does, versus is an endothelium dependent vasomotion assessment abnormal, which is what we uniquely do in the cath lab with acetylcholine and doesn't really happen anywhere else. What are we trying to interrogate? What we're trying to interrogate is coronary flow reserve, which is the ability of, pretty much as already alluded, of any of us to increase our flow by 2, 4, 5-fold in normal circumstances. If that does not happen, that indicates there's an abnormality. So we're really trying to interrogate whether it's non-invasive or invasively, coronary flow reserve, which is alluded, is the ability to increase blood flow in response to alterations in oxygen demand. How do we do this in the cath lab? And I think we're now, we just adopted thermodilution in the cath lab within the past year, but as I said, we're really uniquely positioned that we have PET, MR, and in the cath lab here at Abbott Northwestern, we have Doppler, which Dr. Travers had been using for several years, and just within the past year, we integrated thermodilution. So we have two modalities to interrogate microvascular dysfunction. One which is direct velocities with a wire into the LAD, and the other one is with transit times of injections, and I'll talk about that. Let's talk about first about Doppler. Doppler is the basic standard that I think many have had used probably many years ago, and it's still arguably many people would consider the most comprehensive gold standard to this approach. It's pretty much like the same Doppler from echo. It's just in the wire. It's a tiny wire that has a Doppler probe, and you pretty much align this to get a nice signal within any vessel that you're interrogating. Often the vessel that we like to interrogate, it's the LAD. And if you align that well to flow, you get a nice envelope. To me, the analogy is aortic stenosis. You just want to get a nice envelope and interrogate and get the velocity of that. So how we do that is that we do a diagnostic angiogram. As you can see here, then you can get the different envelopes here. And then you can pretty much afterwards give acetylcholine. And I'll show a case, but that's the basic Doppler approach that has been available for a long, long time. One of the challenges that we have with Doppler is that at this point, there's a shortage of wires, and pretty much thermodilution is being used more and more. But Doppler, as I said, is very comprehensive because you can provide both interrogation of both non-endothelium and endothelium-dependent function. What is the other approach? The other approach is having a lot of traction, partly because it's the one that was used in Carmichael in the trial that I mentioned, is thermodilution. Thermodilution, the analogy, if you want to understand it to me, is just like a swan gans and getting cardiac output. It's just doing saline injections, address, and then with hyperemia. So you bring a wire down the vessel of interest, which is often the LAD, and after doing this wire, you do 3 saline injections, 3 cc each, and that's going to give you transit times. And after that, we induce hyperemia with IV adenosine for a couple of minutes, and then we do 3 injections more. And the ratio of that is going to immediately spit out RFR, which is the resting ratio. Sorry, that's before FFR, IMR, and your CFR. This is one case here from our cath lab, one of the cases that I did recently. And pretty much as I said, you do 3 injections at rest that give you the transit times in seconds. Then we induce hyperemia for a couple of minutes or 2. And now we get hyperemic transit times that we repeat 3 times. And after doing that, immediately, this literally takes less than 5 minutes. The delay is getting the IV adenosine in our cath lab. But doing this, it's literally 2 to 3 minutes. You just do these injections, and as you can see here, immediately you get a lot of information. You get FFR, you get PDPA, you get CFR, and you get IMR. This approach, I would argue, it's very practical and has now allowed the ability that in appropriate cases just to do this ad hoc. So in many cases, I will do it in patients that are, of course, referred for this specific evaluation, and we hold their nitrates, and we hold their calcium channel blockers, and we do this in INOCA patients that are being referred for this particular indication. But on the other hand, this is, as I said, so practical that if it's not for the only variant that we're waiting for the IV adenosine from pharmacy, to be honest, it's something that we're also doing ad hoc right now in our cath lab, and it's very practical. If we correlate this is probably one of the best studies that has correlated the modalities. This is PET versus thermal dilution versus Doppler. Doppler does correlate better with PET, whereas thermal dilution is a more modest correlation. So really, Doppler has been the one that correlates better. And in general, all these modalities appear to not match perfectly, whether it's MR, PET, thermal, and Doppler, and I think that's an area of ongoing investigation. As I said, this is beyond CFR. So if we think about everything that I've talked about right now, thermal dilution with the pressure wire, Doppler wire, PET and MR, focus of CFR. What still makes microvascular assessment completely linked to the cath lab for a comprehensive approach is we can only assess the endothelium in the cath lab. It cannot happen anywhere else. And that's because we need to give acetylcholine to evaluate for spasm. This was evaluated in the Y study. There's a number of other large registries. Stanford, Emory, Mayo have large experience using acetylcholine. This is from the Y study, that if we give acetylcholine, it's very low risk, 0.7% risk of any adverse events. So this is how we evaluate whether patients have epicardial coronary spasm or microvascular spasm. Actually, Tim Henry and the Microvascular Network looked this and published this in JACC last year, 16 studies, over 12,000 patients. The risk of major complications of evaluating spasm provocation is very low, 0.5%. So this is pretty much integrated in the cath labs. So as we wrap up, I really wanted to provide a practical case. This is one of our cases. I don't know if Dr. Zaxina has been an incredible partner with us in sending us patients and also following up these patients. So 70-year-old female, history of hypertension, dyslipidemia with dyspnea and exertion and chest discomfort. She had a previous coronary CT 3 years ago with no significant obstructive coronary disease, coronary artery calcium score of 100. We did a right heart cath early on, and think about what Dr. Cavalcante told you about the association with HFpEF that is increasingly being published and reported. So here you have a wedge of 18, mean pulmonary artery pressure of 30, and a left ventricular end diastolic pressure of 17. I do like, when I can, as much as possible, to always check an LVEDP in these patients early on as my first step. So we go ahead and evaluate the patient and do the initial angiogram. Here's the initial diagnostic coronary angiogram that shows no significant obstructive coronary artery disease in the LAD. So our number one first step is to go ahead and interrogate physiology. We do that with intracoronary adenosine. This can be done, as I said, with thermal dilution or Doppler. This particular case that I'm showing, we use Doppler, and again, that's because at this point, we have the advantage of using both etiologies. This is pretty straightforward. What we do is, and I'll go back here, we position the Doppler wire in the proximal or middle AD. I like to use a microcatheter since the Doppler wire is a little bit stiff and provides more stability. And once it's in position, we administer adenosine intracoronary. And once we administer intracoronary adenosine, we can either with the Doppler or with the combo wire. This is the combo wire. In this particular case, I get all the information at once. I get an FFR of 0.94 that tells me that there's no significant epicardial coronary artery disease. I get CFR, that it's abnormal, of 1.9, and I get a borderline hyperemic microvascular resistance, which is sort of analogous to IMR of 1.9. So a lot of information, again, just within a couple of minutes with some IC adenosine if we have with the equipment available. Following CFR, and that's the reason I said beyond CFR, we go ahead and do acetylcholine spasm provocation, which is the unique thing that we do in the cath lab. Something that is critical for this is to label what we're doing because it's the same picture in the same angle. So if you don't label it, you don't know what you're looking at, particularly afterwards. So here's our first picture, base, showing that there's no significant problems in the LAD. And then we go ahead and start giving escalating doses of acetylcholine. With acetylcholine, the normal response should be vasodilatation, not constriction. That will be paradoxical. So if there's constriction, that means that there is a diagnosis of epicardial coronary spasm. With the Doppler wire uniquely, not with thermodilution, which is a limitation, we can track velocities continuously with Doppler as we do the acetylcholine. So we start doing escalating doses. We get this from pharmacy, and we do 2-minute infusions of acetylcholine. Here's the first infusion of acetylcholine. After 2 minutes, we'll take a picture and see what's happening. We're looking for a number of things. Are there ECG changes? Are there symptoms? What is happening to the velocity if we have Doppler? And of course, and critically, is there any evidence of epicardial spasm? Something that varies per centers is that in this particular case, and most of what I do, it's often with an infusion through the microcatheter into the LAD. If you look at some of the European experience, and other people like Stanford do that, as well as that they just give a bowl of acetylcholine through the left and through the right. So different approaches, but the whole purpose is to try to safely provoke spasm to see whether that's a diagnosis. Here's now to 10 to the minus 5. As you can see, we can label this. We get a velocity. We take a picture. The patient is at this point having a little bit of symptoms. And then we finally do an infusion at 10 to the minus 4. And as you can see, the patient has severe epicardial spasm. This is, again, something that can only be diagnosed in the cardiac catheterization laboratory under safe conditions. At this point, the patient has an unequivocal diagnosis of severe epicardial coronary spasm in the association with HFpEF, with abnormal coronary flow reserve, and we give nitroglycerin. As you can see, everything normalizes. So this is a patient that unequivocally would benefit from vasodilators and nitrates, and that's what was done, as well as optimization of the HFpEF. So at least putting it all together, to me, we're looking at symptoms. Can I reproduce the symptoms in the cath lab with acetylcholine? Are there ECG findings that change? Some people will do continuous monitoring of all leads and see whether there's any ischemic changes to their infusion. We look at CFR, which we do that with adenosine to look at coronary flow reserve. We can do that with Doppler, or we can do that thermodilutions, and the cutoffs are slightly different. With Doppler, it's 2.5, thermodilution is 2.0 as of now. We look at the response of coronary blood flow with acetylcholine. That is a unique phenotype of disease that I'm not showing for the purpose of time, but it's a unique disease, that entity of phenotype of microvascular disease, that if patients do not pick up their coronary blood flow more than 50%, that's a phenotype of microvascular disease. We look at the microvasculature with either IMR or HMR, and we look at vasomotion. To wrap it up here, I do want to talk about treatment. I alluded about core mica before. Core mica is probably one of the best guidance as to how to treat these patients, because again, it's randomized and they had clear strategies as to how to manage these patients. If you had vasospasm, such as the case I showed, they would recommend smoking cessation, calcium channel blockers, nitrates, lifestyle changes. If you had microvascular dysfunction based on an abnormal CFR without vasospasm, they would focus more on beta blockers, ACE inhibitors, statins, and lifestyle changes. And the other thing that we haven't discussed too much, and I think it's also incredibly valuable, is that there are a lot of these patients around that we see all the time in clinic that have a lot of discomfort. They have some sort of chronic angina syndrome. They're on a lot of medications. And sometimes their symptoms may be non-cardiac. So sometimes by doing the evaluation, you can say, this is something else. You actually do not need to be taking IMDR and amlodipine and all this stuff, because you may have something else. So there's also the opportunity to de-escalate medications that are not needed. What comes into, what is coming forward into the future as potential opportunities, something that is of interest is coronary sinus reducer. There's the Coursera 1 and Coursera 2 trials. These are being evaluated with the coronary sinus reducer largely for patients with obstructive coronary artery disease that have refractory angina, because it improves coronary flow. And again, most of the data has been in patients with obstructive coronary artery disease. However, there are ongoing trials. This is one, for example, coronary sinus reducer for microvascular angina, that are evaluating whether there would be a potential benefit of placing a coronary sinus reducer to improve coronary flow reserve and improve symptoms in patients with microvascular disease. The other one is, and I think Dr. Travers had to step out, But the other one is that there's increasing data about stem cells. There's now 2 studies I'm just showing. One here, this is from Mayo Clinic, from Lerman and Michelle Corbin, in which in 20 patients, they did stem cells, and it improved endothelial function, angina scores, and also reduce symptoms of angina and nitroglycerin use. This is actually another study from another group. This is with Tim Hendry. Similarly, 2 centers, small 20-participant trial, but also stem cells improve coronary flow reserve and reduce angina. This is by no means prime time, but appears to be emergent signals of what's happening in this field. The other thing that's happening, and there's a lot of interest in this, is that until now, as I said, coronary flow reserve assessment has existed for a long time. But what's changed is, as I said, the trials and now the data from being in isolated centers, how can we understand this more? So now there's a number of efforts to do registries to understand this in large population data sets. This is one particular registry, Discover INOCA, that is looking at this in the US. So to wrap this up, microvascular disease is common. I think nomenclature has really helped us identify these patients and understand that we should not just say, oh, there's nothing in the arteries, but they can have INOCA or myonocum. It's a spectrum of disease from epicardial to abnormal microcirculation. As discussed, we can assess this with PET or MRI, but arguably that's still the most comprehensive approach because it allows us to assess the endothelium and the non-endothelial function is Doppler thermal dilution combined with acetylcholine spasm provocation, and randomized data is emergent. So with that, I'll wrap it up. Thank you so much. I think we can take any questions if needed. Thank you.
Yader, fantastic. Thank you for doing this, both of you. I want to ask you your thoughts. There are a lot of patients who still have a pain, coronary angiogram, nothing's obstructive, and that's the end of the evaluation. Where do you see it now? How is this going to scale? And whom would you advise that we do more?
Yeah, it's a great question. In the patients that I think, if you have them in clinic, let's say they have a previous CT and we already know they have no obstructive disease, there's a higher pretest likelihood that microvascular disease is a possibility in the diagnosis. I think, for the audience, I think it's very valuable to indicate that you're interested in potentially doing a microvascular evaluation. Because if we want to do this in the most purest fashion, calcium channel blockers and nitrates should be held 24 to 48 hours prior to the procedure, ideally caffeine as well. While we can do the studies radial or femoral, if I know that I'm going to do this, I will admit that sometimes often I'm going more femoral. Reason for that is because these are, as discussed, more often in women. And so these patients, we like to do the studies in patients that we really want them to be awake, particularly when we're doing the acetylcholine, because I want to know whether we reproduce the symptoms, so they cannot be totally out. So if I say, women, let's say they're a little bit anxious, and we do this radial, they develop spasm, and once we give nitrates and calcium channel blockers, it starts obscuring the findings. So to answer, if it's a dedicated study, I think it's often nice to indicate that so we can plan ahead, hold the medications, potentially see whether we do this femoral or radial, often femoral, as I said, and just do a full study and get the acetylcholine from the pharmacy. That's, I would say, for the dedicated referral approach. The other one is that, to your point that we're doing more of that, is that if we do the angiogram, but even if it's not like a dedicated study, if we do the angiogram and there's high suspicion, and we've done several of those recently, particularly with the Abbott equipment that is very facile, we just drop a wire, we just get the through transit times, and then we just give the adenosine for 2 minutes, and within less than 5 minutes, we have all the information. So we're doing more and more of that, and I think it's totally fair game to answer that, because at least we get CFR, FFR, and IMR very, very, very quickly. Doing ad hoc acetylcholine, I will admit it's a little bit of a challenge because it's still, the acetylcholine, it takes 10 to 20 minutes to get it from pharmacy. So often the acetylcholine spasm provocation are more planned studies. Can it be done ad hoc? It can potentially be, but I think we're doing those more planned. But CFR, IMR, ad hoc, I think is fair game.
Great presentation again. Thank you so much. Well, one question.
how often do you actually find in acetylcholine positive test and also microvascular without spasm? And then how about L-arginine? You used to give L-arginine quite a bit for some of these people, but kind of died off. I don't know if there's anything more recently you've seen.
No, I think it's a good point. So the L-arginine is still part of the algorithm. There's no large data. It's over the counter. So I think in general you can still do. What I still do is the basics: calcium channel blockers, nitrates. Make sure that all the risk factors are. But after that, L-arginates are over the counter that can be used and increase some of the vasodilatory function. The data is not as solid, but I think it's fair game. And for example, in my previous practice, it was pretty much standard for everybody to do this. With respect to you were asking about how often they don't have spasm or, yeah. So there's about. It varies because that's the reason, that's the importance of the registries. Right now, most of the data, it's from selection bias populations that are going to some of the centers to get in this. So it's uncertain what is the specific incidence of each phenotype. But there's a number of patients that will have both. There's a number of patients that will have abnormal CFR, microvascular dysfunction with no spasm. But there's also, for example, if you look at the data from Mayo, that as I said, there's a lot of selection bias because these are patients that have had a lot of testing that are traveling over there specifically for that. They do have a pretty notable incidence of patients that will have both microvascular spasm with a normal coronary blood flow and inducible epicardial spasm with acetylcholine. So it's not insignificant, but what is the true incidence of the disease, we don't know. And that's the reason the registry are being done.
What are these people dying from? You show the mortality is increased, and I'm just curious, is this cardiovascular death? Is this just
João, maybe you want to talk about that analysis you showed.
I think it's a bunch of other comorbidities that they have as well. The events also will be driven by the fact that they have non-obstructive coronary atherosclerosis as well. So the lack of awareness that these patients are still vulnerable and remain at risk. There are other cardiomyopathies as well that come with that. So it's a mixed bag and perhaps a more detailed phenotyping, because you could have impaired flow because you now have amyloid or have HCM, you have transplant. There are many other things that would drive the events. It might not immediately kill them, but it kills their quality of life. I mean, sometimes given the diagnosis, it's as therapeutic as starting them on something. Because a lot of these patients have gone through psychologists, psychiatrists, and it's like it's all in your head. And it's not until you can demonstrate that there is something abnormal that we need to work together with therapies and other things that they might start that process as well. But yeah, as your point, I think will be driven by other comorbidities too.
No, and I think thinking about that classification that I showed, the different subtypes, I think your question is totally fair, and I don't know, I mean, the meta-analysis is really good data. But for example, in the type 1, the young woman with no comorbidity, with no minimal comorbidities that have a thermal CFR, high IMR, that's where phenotypes, like long-term studies I think it's a fair question. And I think it's hard because a lot of the other subtypes have cardiomyopathies, LVH, HFpEF. So we need more phenotype-specific sub-studies to really understand this, whether it's cardiac versus non-cardiac.
You have one virtual question. It comes from Dr. Burke, and he asks, are there any data showing that treatment improves outcomes in these patients?
Yes, this is the data that I showed from Cormica. This is really what changed the field. I was here, trained not long ago, and this was an obscure field that we really didn't talk about that much. It totally changed within a few years. Why? Because it was a trial, small trial, but it was well designed. It did not disclose coronary function to those that were randomized to the standard arm, and that improved quality of life in angina. Right now they're doing that trial was Cormica. They're doing, I believe it's Cormica. They have like an INA, and that's a large trial, 1,500 patients looking at outcomes. So that's an ongoing trial. So that at Glasgow, Colin Berry's doing a lot of work in trying to understand that. But whether there's data that we improve hard outcomes, no. I think that is still for quality of life in angina. But that trial was reasonably well designed, particularly with not disclosing the coronary function to the standard of arm, that I think people, that's the reason the guidelines have emphasized it more, because it's thought that we can really improve quality of life in these patients by understanding what's happening.
One thing I would recommend, some kind of checkbox for microvascular, because we'll send people with an equivocal stenosis from nuclear, from CT, from whatever, and they'll say IFR is negative or whatever it is, but that doesn't fully answer the question when they come back to clinic. So if there were some way internally, you could.
Yeah, the other thing is, of course, that not we're still at a stage in the field that not everybody's doing this. The microvascular function assessment, Jay and I are probably the ones that are doing most of it. But I think as people get comfortable with it, I don't see a reason why, particularly with the thermodilution, it's so facile that probably everybody could do it. I do want to add, I know we're over time, but I think it's an important message, particularly since we've talked about different modalities. To me, this is, I don't think that there's a right or wrong. To me, it's totally about shared decision making. So I see that a number of these patients in clinic, and I literally talk to them about like, hey, we can start with an initial evaluation with MR or PET to understand coronary blood flow and get a sense of whether this is an issue. And I talk to them also about the risks and benefits of an invasive approach. It's not risk-free, it's a small risk, but it's a small risk, less than 1%, but it's more comprehensive. And I have a very upfront discussion about the strengths and weaknesses of each approach, and we make a joint decision. Many patients will say, let's start with a non-invasive first. And that's totally fair game. We'll start with that and we'll treat you then. Many other patients said, like, I've had 3 stress tests, 2 CTs, 5 angiograms. I want to get to the bottom of this. And we're like, we're going to bring you to the cath lab, or we're going to get to the bottom of things. So it's shared decision making. I don't think that it's like a one size fits all. And it's important. I think it's important to emphasize, because having done a number of these studies and understanding the risk, also many times they're often healthy young women. Not that it's different doing a CTO in an 85-year-old and having a complication. You don't want to have a complication in a very young 31-year-old with chest discomfort. So I have that very frank discussion, and that's what I would encourage everybody to do. I don't think that it's a one size fits all. Like same as we do for PCI, you discuss all approaches. There may be some patients that want to go all in and get the comprehensive approach. There may be others that want to start non-invasive, and that's fair game. Well, thank you so much, everybody.